Hello, everyone, and welcome back. On Module 125, we talked about the dopamine pathways, right? But let's say that, for instance, one of your patients have EPS symptoms. Well, let's discover together what are the EPS symptoms, how do you treat them, which one is the recommended treatment, and your plan of action. This is Module 126, and it's all about EPS. This is our roadmap, navigating extrapyramidal side effects. Now, what are the EPSs, right? There are those with Parkinsonism, there are those with acute dystonia, TD or tardive dyskinesia, and akathisia, right? There are more, but these are the most important ones. Next, let's find out about acute dystonia. If you have seen acute dystonia, especially if the patient comes through the ER, is rather scary, right? But it's easily treatable. So, what is acute dystonia? Well, simply, it is a muscle spasm of the face, neck, tongue, stiff neck. Okay, uh, and it's very painful. Facial grimaces, right? So a patient who suddenly develops a twisted neck might be experience acute dystonia. People may mistake this for agitation or unusual, especially unusual stereotypical movement characteristic of schizophrenia. So one unique presentation of acute dystonia, it can be said to be oculogeric crisis. Oculogeric crisis. It is a crisis, and we need to fix it, the issue, before it becomes a permanent injury, right? So what happens is the movement of the eye is stacked forward, involuntary upward deviation of the eyes bilateral. I'll provide a picture in a second. What are we going to do? Cogentin. Cogentin, which is the same thing as basotropine. So here is what acute dystonia looks like. Again, it's caused by mostly by dopamine receptor antagonism drugs. Okay, it is a neck and eye facial movement that is very sometimes even disturbing to see, right? Because the patient be stuck, can barely talk. Okay, in practice, I really like to give a antihistamine, Benadryl, for example, IV. So here is what looks like acute dystonia, oculogeric crisis. The eyes are rolled back in the locked position. See, the mouth is open. So that is acute dystonia in a nutshell. And you give benzotropine or cogentin, which is the same thing. Now, if acute dystonia, one is kind of like having those grimace facial features, akathisia, on the other hand, is someone that is restless. They are pacing back and forth. They are in a chair moving. They just seems very anxious, very much moving all the time, pacing, difficulty standing still. Feet is constantly motion and rocking back and forth. An example can be of a patient who can't sit still during a session, may be experiencing akathisia. People often get akathisia mistaken by anxiety, right? What assessment tool would you use for akathisian patient. This is important because you need to assess your patient with those tools. So there are several tools, but the Barnes Akathisia rating scales and the extrapyramidal symptoms rating scales are two scales that we can use to assess our patients. And the treatment option, cogentin. Cogentin can be given. You can also have an option to give a beta blocker, and that would help, or even a benzo. But usually we stick with cogentin. So cogentin for akathisia, cogentin for acute dystonia. Now, here another look of akathisia. Restless, agitated, needs to move, rock, opaque, frantic, panic. So if akathisia was moving, akinesia is the lack of movement. So stand still, right? That's akinesia. So it's the absence of movement, difficulty initiating motions, a subject feeling of lack of emotion to move. For example, a patient accused of being lazy might suffer from akathisia, right? The person just can't move. So it could be mischaracterized by laziness or, in fact, the lack of interest. What you gonna give? Cogentin. So cogentin for akinesia, cogentin for uh, akathisia, and cogentin for acute dystonia. Here's what it looks like in a nutshell, right? So the lack of movement, akinesia. What's next? Well, pseudo-parkinsonian symptoms, right? From the nigrostriatal pathway that we covered early. So symptoms due to the D2, the dopamine blockade, mimicking Parkinson disease. So those patients who have muscle rigidity, shuffling gait, motor slowing, mask-like facial expression, peel rolling, and tremors in the finger. Let's see an example here. A patient who may appear uninterested due to their facial expressions might be experienced by pseudo-Parkinsonian. So, misconception is mask-like facial expression that can be confused with affective blunting or flattening affect. What are you gonna give? Cogentin. What are you gonna give? Cogentin. Okay. So the four EPSs that we cover: acute dystonia, akinesia, akathisia, and pseudo-Parkinsonian, you give cogentin. Now, when we move to tardive dyskinesia, what you not give is cogentin. You don't give cogentin to TD, right? Because it may worsen the symptoms. So for TD, really, you want to decrease the dose, stop the offending agent, or you have an option to give two of the newest FDA approved treatments, which include Austedo or an Ingrezza. So, what is TD? It's an involuntary abnormal muscle movement of the mouth, tongue, face, and jaw. It may progress to the limbs, right? Usually, you would see TD with antipsychotics. There are other medications like Raligan that could cause TD as well, but antipsychotics are the major class of medications, and usually after 2 years period, and less so with the second generation compared to the first generation, right? So, for example, can take up to 1 to 2 years to occur, and acutely during the initiation of a chronic conditions, as may point in the treatment here. So we would look for reduction of the current dose or change of the medication. There are two FDA approved medications that we can try called Austedo and Ingreza. So your action is to decrease the dose or change to another antipsychotic. That being said, what other antipsychotics would you choose to? What which antipsychotics is known to be less prone to EPS symptoms? Well, in practice, when the patient develops EPS, I like to go with the chlorazil. Okay, so let's go on with Raligan. Raligan, it's a drug that's not a antipsychotic, but can very well cause TD, right? Can cause EPS like tardive dyskinesia, TD, and pseudo-parkinsonism symptoms. So how can you remember the extrapyramidal side effects? Think of this as drape. So, which is dystonia, restless, which reminds you of akathisia, A for akinesia, P for parkinsonium, and E for exaggerated movement, which is the TD part of the acronym. So, drape. So that being said, if you ever have a patient that develops one of the symptoms early of, let's say, acute dystonia, akathisia, akinesia, so they would be most likely prone to develop TD later on. Remember that. That's important for your patient care. My name is Dr. Lopes, and I will see you on the next module.